To understand localization wire migration, we need to first understand why and how needle localizations are performed. There are two reasons for this procedure. First is to biopsy a suspicious region of the breast that might have cancer. The second reason is to remove known breast cancer. Surgeons call the procedure a lumpectomy, and radiologists call it a needle localization, but these terms are interchangeable. This is how a needle localization is performed. A radiologist puts a needle into the breast which has an internal wire. When the needle and wire are in good position, the needle is removed, leaving only a wire. The patient is then taken to the operating room, where the surgeon will follow the wire to the region of cancer or suspected breast cancer and take out this tissue. This tissue specimen is then taken back to radiology for an X-ray. This X-ray shows if the biopsy was successful. The time between when the needle is placed in radiology and then taken out by the surgeon in the operating room is usually about 4 hours. During this time, that wire can move. The most common type of movement is the wire being accidentally partially withdrawn. There are multiple scenarios in which this can happen. It can be inadvertently withdrawn while the patient is being transferred from a chair to a bed, or from a gurney to an operating table. Also, the patient can inadvertently remove the wire when they get up to use the restroom. The second type of movement is when the wire works itself deeper. In medicine, we call this migration. What happens is that as the woman breathes and moves, tissue builds up behind the hook of the wire and drives the wire deeper. Unfortunately, the heart and lungs are very close to the breast, and these wires have been known to migrate into the chest and collapse a lung, or even worse, penetrate the heart, causing bleeding around the heart, known as a cardiac tamponade. There has been a reported case where the wire worked itself through the heart muscle and started migrating through the aortic valve and into the aorta. The repair for this case was open heart surgery. If left alone for years, these wires have been known to migrate as far as the knee. These cases of wires migrating out of the breast are rare. What isn't rare is migration within the breast. When this happens, the wrong region of the breast is biopsied. Here's how this works. Let's say the wire has migrated 3 inches deeper. The surgeon has made one attempt to remove the region of interest, but this first attempt failed because the wire hook was too deep. Now the surgeon goes back into the breast and takes out more tissue. But this time there are no landmarks or wires to guide the surgeon. So he or she takes out more tissue in generally a 360-degree area. With each additional attempt, more and more tissue is removed. Usually after 3 or 4 failed attempts, the surgery is aborted and the patient will need to be rescheduled for another wire localization and biopsy. When a biopsy is performed, ideally a small amount of tissue is removed. Typically this is the size of a cherry. When the wire has migrated and multiple attempts are made to find the correct tissue, the amount of removed tissue goes from the size of a cherry to a plum, then a peach, and then maybe even the size of an orange. This large amount of removed tissue often results in a deformed breast. In the past, this was not an issue because virtually all women with breast cancer were getting mastectomies. Now with early cancer detection, as well as better chemotherapy and radiation, mastectomies are becoming less and less necessary. Remember, some needle localizations are performed when cancer is just suspected. So when these patients end up with a benign diagnosis, they of course don't get a mastectomy. Now they either live with a deformed breast or go to a plastic surgeon for reconstruction. There is a simple solution to this problem of wire migration, and that is to secure the wire to the skin as it exits the breast. This is performed with a device called WireFix. This device has a sticky adhesive on the undersurface and a plastic clip on the top surface. The device is placed on the skin and the wire is immobilized with this clip. This device also comes with cover strips which have adhesive on 2 parallel sides. These strips cover the exposed wire without the wire coming in contact with adhesive. This simple device solves both accidental withdrawal of the wire and deeper migration of the wire.